Okay, so this video is going to be talking about scheduling for a possible root canal and how that works out with the appointment book. So let's go over some clinical situations and kind of show the difference between what we might run into. First of all, possible root canal situations. There's really just going to be two of those. It's going to be somebody who has a deep decay, but there's no infection seen on the x-ray. Or it could be someone who has a cracked tooth but they've got sensitivity. Again, there's no infection, but they just have sensitivity when they're biting on a tooth that has a crack in it. Let's kind of go over some basic decay progression slides real quickly to kind of show how this whole thing works. So here's your typical cartoon where decay starts at the enamel, works its way through the dentin, all the way into the pulp, and then the pulp dies, the nerve tissue, the blood supply die away, and then you have what's down at the root tip called an abscess, or we call it an infection. Here's a couple of examples. Filling, deep decay, all the way down. You can see this dark spot right here at the root tip. Here you can see another one. The arrow is pointing right to the dark spot. Here's another one, an old filling or a filling that's really, really close to the pulp. And I'm sure that was placed years ago, and now the tooth has finally died away. So it can either be from deep decay or it could be from a previous treated tooth. And the nerve just dies away, or the pulp does, and you can wind up with an infection like that. So those are cases where it's 100% chance it needs a root canal. There's no question about it. That needs to be treated. Okay. But what about these other ones where we have some areas where there's quite a bit of decay, but we go down to the root tip and there's no dark spot, there's no infection. Here's one where there's two teeth have got deep areas of decay. This one has an infection right there. It's kind of slight compared to those other films we just saw, but this one doesn't have any infection going on currently. At least nothing is showing up on the x-ray. That doesn't tell us for sure, though, if the decay has gone into the root canal. It just hasn't resulted in an infection yet. Here's another one, deep decay, root tips are okay. Deep decay, root tips are okay. Again, that looks fine. So just because there isn't a dark spot, it doesn't mean that they don't need a root canal. It's just that it hasn't developed into an infection yet, or it may never. Now, some of these that the decay or the fracture is so deep, the teeth may not even be restorable. But let's just assume that the teeth can be restored. There's a chance we get in there, remove the decay, and it doesn't go all the way into the pulp, in which case we don't have to do a root canal. We just end up putting a very large filling, or most of the time it's going to be a buildup in a crown when the decay is that big. Here's a cute little cartoon basically saying, oh no, it's gone through the dentin. Well, how do we know how deep these areas of decay have gone through the dentin? And this is what makes it kind of tricky. This is why we say there's a possibility of a root canal. We may even attach some kind of percentage to it. But if you would take a look at a tooth and look at the x-ray, these are things I've gotten off the internet where someone has taken an x-ray of a tooth, and then they took that tooth and cut it kind of lengthwise in half to kind of show, well, how far is that decay in reality compared to the x-ray? And they try to match them up. Here you can see the decay has gone through the enamel. It's now into the dentin, but it looks like it's just right here. But you can see, really, it's gotten much deeper. There's even a little spot right here in the mesial of that tooth. And look, at once it goes through the enamel, it hits the dentin. Now you know why that guy is so concerned, because it's gone all the way in, and once it hits the dentin, it really kind of expands laterally and goes towards the pulp. Here again, enamel, dentin. That doesn't look as bad. It's actually trying to make looks like a beeline right for the pulp right there. It doesn't like just shoot across the tooth. It actually looks like it heads right towards the pulp. The reason being is that the dentin is made up of a bunch of little tubules, like little straws that start from the pulp and will kind of radiate outward. And so when decay gets into the decay, it kind of gets into those little tubes and goes right towards the pulp. Here again, small little spot on an x-ray. There's many times I'd probably say, oh, that's just a watch or maybe just an MO filling. But sometimes when we get in there, the decay is much bigger than what the x-ray would lead us to believe. So that's why we have this kind of, it's a possible root canal whenever we see the decay is deep. But now let's move on to a cracked tooth. Patients come in and we see cracks all the time, kind of like this. This person has multiple cracks. Yet some of these patients don't feel a thing when they bite down on it. It feels just normal. Yet you could have somebody else that might have a silver filling and a crack right here, and they probably have a crack right there. If you put a bite stick on here, they would jump when you put the bite stick and test this cusp. You might test that cusp and everything is fine, and that one's good, and that one's good. But when they bite on this one, it hurts. The patient may show up and say, every time I'm chewing on this tooth, it hurts. Well, that's when we go through our test and take a look to see, do they have a crack? Now, interesting for people who don't work chairside, for assistant for hygienists and front desk. When we take out these silver fillings, sometimes we see cracks running right along the floor of the tooth. You can see another one running right there, right along the floor of the tooth. And the thing is, we don't know how deep cracks go. These are layers to the tooth, so we can see the crack from the occlusal. But once we lift the filling out, we can see the crack might be actually laying on top of the dentin. And we're not going to go chase a crack down to see how deep it goes. But when patients come in and they're having sensitivity, there's a good chance that that crack is going down and maybe just irritating the pulp enough that it may just need the tooth to be crowned to hold it together so it no longer flexes apart. You put a crown over the top of it and you hold it together. So, but sometimes though the crack has gone so deep that even if you do put the crown on top of it and the tooth isn't flexing, the irritant from the crack is so deep that they're still going to feel it no matter what. So the thing is, we don't know until they're wearing the temporary if they're going to have their symptoms subside or not. So that's why when someone comes with a cracked tooth, we say, you may need a root canal. We're going to bring them in for the buildup in the crown, but then we're going to put them into a temporary crown and send the crown off to be made. But while they're wearing the temp, if they still have the sensitivity, then that's when we want to get that root canal taken care of before we put the final crown on. Because it's much nicer to have the root canal done and then put the final crown on, as opposed to put the final crown on, see if the sensitivity goes away. And if it doesn't, now have to drill a hole right through this brand new crown to do the root canal. Now we can patch it up and it will work for many, many years. But if someone has just paid for a crown, I think they'd prefer it not have a hole drilled right through the middle of it. So that's why we tell patients, look, there's a chance you might need a root canal. Let's let you wear the temporary first and see how you do. Okay. In some of those cases, we may treat those root canals here, but more times than not, when it's a cracked tooth, I know my preference is to just send it to the endodontist, because sometimes these cracks go so deep, they go down inside the root. And there's no way that I can see that. The endodontist can see it with their microscopes. And if it goes down that deep, then a root canal is not going to even work for this patient. That entire tooth needs to come out. And so I'd rather the patient get treated with a specialist with that situation. So let's kind of run through these different scenarios then. So you have a person coming in, 100% chance for root canal, deep decay. There's no crack here. This is just deep decay. We can see the infection at the root tip. This is 100% chance root canal. The note for the appointment book is going to be patients coming in for a buildup, crown, and 100% root canal. Okay. We're going to treatment plan for all three, and we're going to schedule for all three. And we're going to collect for all three. It's the whole thing. We're going to be set up in the room to treat for all three of these procedures. Okay, now we have another one, deep decay with possible root canal. Now this is the one again, deep decay, but there's nothing at the root tip. There's a chance, maybe. This x-ray in particular, I'd probably say there's about a 90% chance, 90% chance that this is going to wind up with a root canal. So we would go ahead and, even if I said if the chances of this was 50%, or if let's say it's not as extreme as this, but there was a chance. If I said, there's about a 20% chance this is going to need a root canal. If there's some kind of percentage of a root canal that's less than 100%, we're going to put in note for the appointment book, buildup, crown, possible root canal. We're going to treatment plan for all three. We're going to schedule for all three of those to happen. We get into the middle of the appointment and it turns out they don't need a root canal. Great. We subtract the root canal from the appointment book. We subtract it from the chart. We subtract it from, I don't think the ledger would need it at that point, but we would take it off the patient's chart and we would just go ahead and proceed. We usually give the patient a warning and say, there's a chance this tooth at some point down the road may need a root canal. But for that appointment, if it did not go into the pulp, we are not going to do a root canal. This one, however, cracked tooth, they have sensitivity, bite stick sensitivity, or patient has chewing sensitivity, but there's no infection on the x-ray. Okay. Note for the appointment book, buildup, crown, possible root canal. Referral after wearing temp. I'm sorry, back up. Buildup, crown, possible root canal referral after wearing the temp. That would be the note in the appointment. We're going to treatment plan for buildup and crown, not the root canal, because if this is going to need a root canal, then we're going to send it to the specialist. We're going to schedule for just the buildup in the crown. Because remember, the patient's going to leave with a temporary, and we're going to see, hopefully, that tooth will settle down and they won't need a root canal. If, however, while they're wearing the temporary, if their sensitivity persists, then they're going to get referred to an endodontist. Or if the dentist here wants to do the root canal themselves, they can do it too. But the point is we're not going to be scheduling for or collecting for the root canal on that visit. We're not set up for root canal on that visit because we don't know yet until they have worn the temporary for a few days. So again, 100% root canal, that's a no-brainer, easy. Deep decay, possible root canal, we're going to be set up for it just in case. When it's a cracked tooth, we're going to do buildup in crown and see if they need a root canal. Okay, so hopefully that kind of clears up how we're going to schedule and book these appointments and make our appointment notes so that when that patient arrives, everybody knows what the plan is. All right, take care. Thanks.